So the most famous effect is that at some cells of the body, like muscle cells or fat cells, not every cell, some cells, insulin will knock on the door, and then other doors will open, allowing the glucose to come rushing from the blood into some of the cells of the body. Again, that's the most famous effect, and that can matter clinically. Now, over time, some cells of the body start to resist the signal. They're not responding as well to insulin as they used to. That is the insulin resistance part of this definition, although it's not complete yet. But as a result of this, it's no surprise that the most famous effect isn't working very well anymore. And whereas a little bit of insulin was sufficient to keep blood sugar levels at a normal level, now that some cells aren't responding as well to the insulin, the blood sugar levels start to go up eventually. And this becomes, of course, a very obvious clinical sign of the problem, albeit late, as I'll come back to in a moment. Now, at the same time, if this given amount of insulin is insufficient to elicit the action that the cell is wanting, that the body is wanting to maintain normal function or homeostasis, as we would say in the realm of physiology, if that amount of insulin is insufficient, well, then the body can make more insulin. And what was once one polite molecule of insulin knocking on the door becomes an angry mob pounding on the cell, all in an effort to try to take what is now a diminished action and restore it to the robust action that the body is looking for. All right. Now, in the midst of this definition, I have actually discussed two aspects. So insulin resistance is a coin with two sides. One side of the coin is the obvious phenomenon where some cells aren't responding to the hormone insulin as well as they used to. That's the obvious part of what we call insulin resistance. But there's a less obvious but equally relevant part of this as we flip the coin over, and that is if we move out of the level of the cell and encompass the entire organism, the body, now we determine that blood insulin levels are significantly higher. So this is essential. There is no such thing as insulin resistance without hyperinsulinemia, or in other words, elevated blood insulin. These two things will always come together in every instance of insulin resistance. Now, the paradigm that I've presented actually has planted this directionality in your minds, which is that insulin resistance is leading to the hyperinsulinemia. That is not wrong, but it's not complete. We're going to come right back to this paradigm in just a few minutes. All right, now let's shift the paradigm even more oddly and look at an individual over time who is slowly experiencing an increase in his or her blood glucose levels. And they're becoming ever more and more diabetic. Type 2 diabetes is a disease defined by the glucose. That is the clinical diagnostic. It is purely based on blood glucose levels. Interestingly, it is purely a problem of insulin resistance, as I'll show you. Now, this is what the glucose looks like. However, if we were to superimpose insulin, it would look like this. If we had a clinician who was aware enough of the problem, or a patient who was aware and insisted sufficiently that we should also measure insulin, we would get a curve that would look like that. And you can see they do not run together. And this is on the time frame of years. So we're following the person through decades of life. Now, there are two, perhaps among more, time points here that I believe are relevant. This first time point is insulin resistance. When blood glucose levels are normal, thus flying under the clinical radar, which is based purely on looking at glucose, but blood insulin levels are significantly elevated. This is a state that can last for decades. And then eventually, the body starts to become so resistant to insulin and or the insulin production starts to come down a bit, but never going to zero. If this is type 2 diabetes, they start to move into type 2 diabetes. So type 2 diabetes is when the insulin is still elevated, but so too is the glucose. Now, the problem with the conventional clinical paradigm is that we have a glucose-centric view of metabolic health. And that's not wrong. It's okay for our perspective to encompass glucose. But if we are doing so at the expense of overlooking insulin, then we are missing the early metabolic signal, the canary in the coal mine that could have warned this clinician and patient that there's going to be a future problem would have come from encompassing or having our clinical view be more insulin-centric on the problem. That makes sense. If we appreciate that type 2 diabetes is in fact a disease of insulin resistance and all those other chronic diseases are also derivative of insulin resistance, well then let's look at the insulin.